Hi, my name is Federica Genovese, and I'm a postdoc fellow at the Monell Center in Philadelphia. So the Monell Center is a research center that focuses on studying our senses of smell and taste. Loss of smell and the resultant loss of the perception of flavors, like in beverages and food, are common occurrences during the upper respiratory infections. In the current times, during this COVID-19 pandemic, there's been an increase of reports of olfactory loss, which is known as anosmia. So based on these observations, in March, different medical societies from the UK and the US recommended those patients who has no other symptom than a sudden olfactory loss will self-isolate it, assuming that they might have contracted the virus. This will help out to avoid the spreading of the virus throughout the society. However, smell loss can occur for many other reasons, not only for a viral infection. And there's no reason to think that who actually had lost their sense of smell before the pandemic could actually have higher risk to be a carrier of the coronavirus. It is currently investigated how olfactory loss correlates with the COVID-19 infection. So in today's talks, I'm going to present mainly two papers. But with the help of others, I'm going to make the situation more clear. So the two papers are, one is a big review on post-viral olfactory loss. And the other one is a report of olfactory and taste disorders in COVID-2 patients, which has been conducted in Italy in the recent months. As I said, I'm going to use more papers to try to fill up the gaps in this presentation and make it more easy to understand and to have a broader overview of what is going on right now. Let's start from the beginning. What are olfactory dysfunction? Specifically, we have four different kinds of olfactory dysfunction: phantosmia, parosmia, anosmia, and hyposmia. Those can be divided in qualitative and quantitative. Qualitative dysfunction are phantosmia and parosmia. So in those cases, the patients can smell, but they have a completely distorted perception of the odors. While for anosmia and hyposmia, those are quantitative olfactory dysfunction. In anosmia, we have the complete lack of the sense of smell, while with hyposmia, we have a reduction of the sense of smell. But olfactory dysfunctions can be also classified due to the physical reason why they occur. So we have conductive olfactory dysfunction, where basically the airflow cannot get into the turbinates and reach the olfactory epithelium, the organ which is detecting odors. And this could be due to very different reasons, including polyps or an infection. The other olfactory dysfunction could be classified as non-conductive or sensory neural. In this case, there's basically the degeneration of the organ which is detecting odors, which is the olfactory epithelium. This could also be due to very different reasons. One of this could be the head trauma, so when cutting out the olfactory neurons, causing the degeneration of the olfactory epithelium. But other reasons, like a viral infection or the exposure to the toxin, can also be a cause of olfactory dysfunction due to the loss of neuronal activity. So viral infection is the most frequent cause of olfactory dysfunctions. And it usually starts with a congestion, which is causing a conductive olfactory dysfunction. After this, we could have either a recovery of the olfactory functionality or the progressing of the dysfunction to a sensory neural olfactory dysfunction, which is secondary to the viral insult. After this dysfunction, of course, we can still recover from it. Or, unfortunately, in few cases, there is a permanent olfactory dysfunction. So there's a permanent loss of the olfactory ability. So what we need to know, and it's important to keep in mind, is there are 200 different viruses that could cause a cold, but not all colds can actually lead to a permanent olfactory dysfunction. Many, they do it temporarily, but the recovery is always happening in the time. Approximately 23% of all olfactory loss cases are caused by upper respiratory infection. And this data is pretty much consistent through different centers. So these centers, they usually treat patients that have olfactory loss, and they all reported a percentage that goes around this 23% of patients that can recall an olfactory respiratory infection as the origin of their loss of the sense of smell. So in sensory neural olfactory disorder, so if we look only at the category of this specific disorder, the upper respiratory infection is the most common cause. and occurs in approximately 42.5% of the patients. But which is the pathophysiology? Well, we don't know really much which is the physiology behind this olfactory loss. There are two different theories. One of these is actually pointed out to a peripheral degeneration and damage of the olfactory epithelium, which is causing then the loss of sense of smell. But there's also a theory that points it out that damages at the central nervous system, so in areas of the brain which are processing the olfactory information, could cause the loss of the sense of smell. So there are really few reports on the scientific point of view that could actually follow up a little bit more on the histology of the olfactory epithelium during a post upper respiratory infection. And one of the few is this one from 1990. And what we see is basically stainings with biopsies of the olfactory epithelium at different time points. All of those were taken from different patients. So we can see at 20 days, 3 months, and 2 years how the epithelium of those patients, which had no olfactory sensitivity, actually look like. So at 20 days post upper respiratory infection, which could literally be just a cold, what we see stained here by NSE are single olfactory sensory neurons. Those neurons are necessary to detect odorants in the air that we breathe. So here, as you see, in 20 days, there are actually a reduced number of those neurons, which is probably the reason why the patient could not really smell. While for this sample at 3 months, in figure B and C, we can see, again, staying with NSE, olfactory sensory neurons. And in this case, we could also see that in comparison with a healthy one, we have less olfactory sensory neurons. But still, they look a little bit more in comparison with the 20 days subjects. What we can also see in the following staining is that S100 marker for the neurons as well. So the axons of those olfactory sensory neurons are still in the basal lamina. The other two stainings in the bottom at 3 and 2 years post upper respiratory infection are looking to a different cell type of the olfactory epithelium, which are the supporting cells. These cells have, as the name says, the function to support the olfactory sensory neurons and basically maintain the homeostasis of the epithelium. As you can see, at 3 months, basically seems to be a kind of increased number of these supporting cells, suggesting a reduction, though, of the number of olfactory sensory neurons, looking like the supporting cells will replace the olfactory sensory neurons. So in the last samples at 2 years post upper respiratory infection, what we see is that the olfactory epithelium looks completely different from a healthy one, and we have a really increased number of those ketokeratin positive cells. So this epithelium looks now more like a respiratory epithelium, which is one which is unable to smell anything. So overall, from these stainings, what we can see is that patients with post-viral olfactory loss, the olfactory epithelium looks atrophic and thin, which is the reason why they could not smell much anymore. So, but let's look a little bit more at the numbers. So patients with post-upper respiratory infection usually are more hyposmic than anosmic. That means that basically 43% of them have no sense of smell at all, while 57%, so the majority, have only a reduction of the sense of smell. This picture looks completely different from other olfactory loss due to different causes. So post-trauma, which is a more broader damage, we see that basically 73% of the patients suffer a complete loss of the sense of smell, while only 27% have a reduced sense of smell. Another example is the postnasal sinus disease. So in this case, there's an infection going on into the noses of this patient. And here you can see that the picture looks more similar to the upper respiratory infection, where we have basically 58% of the patients being anosmic, while 38% being hyposmic. Somehow in the numbers, 4% was missing, so we don't really know what happened to them. I hope they're fine. But can we recover from an olfactory dysfunction due to an upper respiratory infection? Well, data show that actually time is really helping a lot in this. And this study, together with others, show it quite nicely. So let's look into this data a little bit. So in this case, they follow up in time 63 patients. They initially divided them in 3 different groups using a very objective and quantitative test, which is the odor threshold test. And so this way they could actually classify them in anosmia, severe hyposmia, or mild to moderate hyposmia. So then what they asked to those patients is actually to give a rating, a score to their olfactory perception. And what they saw is that actually the result of their quantitative test and the subjective olfactory score were pretty much correlated. The score that they gave is the one that is indicated here in those 3 graphs as initial. Then what they did is following up in times, basically giving a phone call to those patients and asking them to rate again their olfactory perception. And what they saw is that basically on all these 63 patients, 85.7% actually show an improvement in time of their olfactory function. One important thing is actually to notice is that in the first 6 weeks of the study, these patients were treated with corticosteroids, but no longer than that. And so all the time after, and they went up to check on this patient for 33.4 months, so a really long time. Still, they had the final rating, it was strongly improved. So, as we said, 85.7% improved, but how do the different categories improve? So we see that the anosmia group actually improved up to 77.8%, so quite a bit jump. The one that improved the most was the hyposmia, severe hyposmia group. The improvement rate was 19.9%, while the mild to moderate hyposmia group, they also improved quite a lot, went up to 87.0% of the rate. So in comparison with the beginning of the test, so all of those were improving up to, let's say, in average, around 85%. So this is actually showing quite nicely that quite a big percentage of those that have an olfactory dysfunction due to an upper respiratory infection, they do have a really wide margin of improvement. Let's look a little bit more which are the alternative or possible therapies that can actually boost this improvement or helping out even more. What we know is actually that more than time, there's no really a known and confirmed therapy which is really effective, except for one which is really, really promising. And I'm going to talk about it a little bit later in this slide. So let's talk about the first 3 therapies. So all of those studies have a big flow. So in none of those, they actually use a control group. So we see, for example, that in the first therapy, intramuscular beta-carotene or vitamin A injection, 22 patients on a number that actually we don't know which is the total number, were actually improved. But again, we had no control group. That means that we don't know if those patients actually improved because just time passed by or because our therapy was actually really effective. Another treatment that was tried was the application of oral vitamin B12, adenosine triphosphate, and betamethasone nasal drip. So in this case, 21.8 patients almost recover their olfactory function completely, while 21.8 slightly improved. Also in this case, there was no control group. So we don't know if their improvements were due to the treatment or just by the time. Another therapy that for a while was thought to be very, very promising because they show something like 61% of patients improved was the administration on alpha-lipoic acid for 3.5 months. So here you can say the time span is very, very wide. Well, in that case, again, there was no control group, and with a follow-up study where they included a group of controls, actually what we see is the improvement was not confirmed, meaning that most of those patients improved because time passed by and not because of the therapy. But what is actually really effective right now is the smell training, which can be associated also with the application of nasal corticosteroids. This smell training has been asked to the patients to do it for 12 weeks, and it's literally a training, just a workout for your nose. And so patients are asked to sniff a bottle of essential oils of 4 different things, which are rose, lemon, eucalyptus, and clove, and do it 2 times a day. The importance of this training is actually really, even if you don't really smell anything, is try also to get any note possible you can, or just trying to remember how the smell like. And so what we see is that basically 27.8% on 56 patients actually strongly improved due to the smell training. And the one here mentioned is not the only study that actually showed that. There are several papers and studies that repeated the smell training and followed up patients during the smell training for even longer. Again, what is important in this study is that there was a control group. So patients which had anosmia or hyposmia, and they were not asked to do smell training. And the improvement over them of those that were doing the smell training was significantly higher. But let's look a little bit more to the current situation. And what's the coronavirus? The name is kind of indicating its own structure. Corona in Italian, I'm not sure also in Latin, means crown. And this is referring to these spikes which are protruding by the membrane. Right now we are in the middle of a big coronavirus pandemic. Coronavirus is a big family of viruses. There are many which have a very similar structure, but most of them actually cause only mild upper respiratory symptoms. In the last century, actually, we experienced 3 main outbreaks where the coronavirus and their symptoms were much more severe. And those are the SARS-CoV in 2003, MERS in 2012, and of course the current COVID-19. So differently from SARS and MERS, COVID-19 seems to be way more widespread through all the global population. And it's raising a lot of concernings. Interesting, with the outbreak of the COVID-19, there was an increase of reports of olfactory and taste disorders. And in this study that I'm going to show, is kind of shows some preliminary data from COVID-19 patients in Italy. Those patients, it's important to point it out, were all hospitalized. So it's only a small portion of the whole population that contracted the virus. And so from this Italian study, what we see is that 18.6% of the patients that reached the hospital had taste and olfactory dysfunction, while 15.3% had either taste or olfactory dysfunction. Other important information that were included in this report is that 20.3% of the patients had olfactory and taste dysfunctions symptoms before reaching the hospital, while 13.5% developed olfactory and taste dysfunction during the hospital stay. Also, what is important to notice is that 91% showed taste alteration before reaching the hospital, but this number kind of went down while they were at the hospital to 50%. This is an important point to look at. So usually taste alterations are really hard to figure out because are very often mixed up with flavor perception. So the flavor perception is the sum of taste and smell. The loss of smell is usually reducing our perception of the flavor. The taste perception is by itself the perception of sweet, sour, salty, and umami, and bitter. So taste alterations and these reports are always harder to figure out how many of those are really taste perception, changes of the taste perception, and how many of those are actually a change of the perception of the flavor, and so are due to the loss of the sense of smell. Another important point that was shown in this Italian study is that olfactory and taste disorders are common in a population which is slightly younger than those that don't have it. So people with olfactory and taste disorder were on average 56 years old, while those that did not have them have a higher average age, which is around 66 years old. What we also want to point out is that the population that was hospitalized in Italy also had on average a higher age than the ones which has been affected in other countries. Another important bit, which is actually reflecting some previous studies, is that females are more prone to report olfactory and taste dysfunction. Now, in this study, they showed that 52.6 women reported that. And the reason could be several. One could be just because females are just more prone to have it, or females are actually more prone to report it. Very recently, also another study, in this case from Iran, trying to look into the current COVID-19 outbreak and olfactory and taste disorders. So differently from the Italian study here, the Iran study was by self-report during an online questionnaire. So they were able to reach out for a wider population. So in that case, they tested something like more than 10,000 participants. And what they did, and to can show very, very nicely, as you can see in this graph, there's a correlation, a significant correlation between the increased number of COVID-19 cases and an increased number of anosmia and hyposmia reported. So this is really showing that hyposmia and anosmia can correlate with the COVID-19 outbreak. What they also show is that basically 72% of the responders show or reported to have a sudden olfactory loss. And if you see in this graph, basically 0 means they have no sense of smell at all, while 10 they have a full sense of smell. And so we have 17.3% of the people that responded to this questionnaire actually having no sense of smell at all. And the percentage, it really stays up also for reduced sense of smell. They also tested out the taste sensation. So here the result is also quite surprising. So we see that 70.5% of the patients, or the people that responded to the questionnaire, declared to have no sense of taste at all. So this is a bit odd and strange for what I said before. So usually perception of flavor and taste are really mixed up. And so I find very interesting that here the numbers between those that show no sense of smell and those that show they declare to have no sense of taste are not as similar as I would expect to. Overall, we can say that also in Iran, we have almost 60.9% of patients, basically they had anosmia suddenly with the outbreak of the virus, and also 83.38% of the patient, of the subjects, showing to have decreased taste sensation associated with COVID-19. So now let's look back to a viral infection and how we perceive it. So we start with the congestion, as we said, and then we could actually recover our olfactory function, or we can have basically olfactory dysfunction due not to the congestion anymore, but to the sensory neuroolfactory dysfunction. And then from that, we can, of course, recover again or have a permanent olfactory dysfunction. Well, there's a big difference with the COVID-19 is that the congestion, which is common in any cold, is not present here anymore. So this could be actually a reason why there are so higher number of reports of olfactory loss with this virus. We are used to associate congestion with olfactory loss, but we are not used to have olfactory loss without congestion. So in this case, we have no congestion, but we only have olfactory loss. Another thing which is very important to point it out is that, yes, we are having a lot of reports of olfactory loss, but also we have a lot of reports of people recover from this olfactory loss quite quickly. So either 1 or 2 weeks. This makes our hope and, of course, think that the olfactory loss that we are seeing with COVID-19 are actually not permanent in most of the cases. Again, here what we can say is that basically the lack of congestion might unmask the post-viral olfactory loss. What we know about the virus, and can this pandemic actually help us out to understand why we have olfactory loss due to a virus infection? So we know that COVID-19, so the coronavirus, can interact with many of our cells through different receptors. The receptor is called AC2 receptor, and we know that there needs to have a cofactor called TMPRSS2 to be able to actually infect a cell. This is one of the pathways that has been identified lately. This is, of course, not the only pathway though. But now let's consider this pathway. The next question is, are AC2 and TMPRSS2 in the olfactory sensory neurons? So are the olfactory sensory neuron presenting the molecule necessary to be infected by coronavirus? And this question was addressed by a study which has been out very, very recently. So what they see is that from the analysis of RNA sequencing datasets of the olfactory epithelium, they could show that the olfactory sensory neurons do not express any of those molecules, but another cell type in the olfactory epithelium is showing them, and those are the sustentacular cells, or supporting cells. These cells have a very important function in the olfactory epithelium because they maintain the overall homeostasis of the epithelium, keeping it basically healthy. So the study then is therefore suggesting a possible pathway by which the COVID-19 could affect the overall function of the olfactory epithelium. So what we know is that these molecules are actually expressed in the olfactory epithelium, but not in the olfactory sensory neurons, but in the supporting cells. The function of these cells is quite important for the maintenance of an overall healthy olfactory epithelium. And so a degeneration or a damage of this cell type could cause the overall loss of olfactory function. Of course, this is only one possible mechanism of action for COVID-19. There are other mechanisms that could be thought about. And a good way to think about it, or actually to consider them, is looking at what other coronaviruses are using and see where those are expressed in the olfactory epithelium. So here in this graph, what we can see is that, for example, SARS is using AC2 as SARS-CoV-2, so COVID-19, but also is using another infection factor, which is called TMPRSS11D. And in that case, this factor has a similar pathway or distribution as TMPRSS2, with a big difference though that it's highly expressed in the respiratory epithelium, but not really much in any cell of the olfactory epithelium. Another interesting coronavirus to look at is actually the common cold coronavirus, which is called HCOV299E. And in that case, we can see that this furin, which is the molecule necessary for the common cold virus to infect our cells, is actually expressed in the olfactory sensory neurons. Of course, this doesn't mean that furin could be a possible factor, but we want to, of course, keep our mind open and think about alternatives, how this coronavirus can actually affect our olfactory system. So now we know that COVID-19 can enter the peripheral nervous system, but can it actually reach also the central nervous system? Well, we know that the olfactory system is a very good way for many drugs to be able to pass the blood-brain barrier and reach the brain. And so why not the COVID-19? So right now we don't have an answer to this question, but a previous study on SARS actually showed that the virus used this pathway to reach the central nervous system. In the study that was conducted on mice, these mice that were transfected with human AC2, which is a factor that helps SARS-CoV to infect the mice cells, but let's also remember AC2 is essential for also COVID-19 to infect our cells. Well, we see that those mice, when injected intranasally with the virus, they actually show 60 hours post-injection the presence of the antigen of the virus also in the brain, and especially in the olfactory bulb, which is the first area of the brain which is processing the olfactory information. So we see that at 60 hours post-intranasal infection, the olfactory bulb expresses a really high level of SARS-CoV antigen, which is shown in image A with the purple color and indicated with OB. While we also see that 3 days post-intranasal injection from the olfactory bulb, the virus could actually spread in different areas of the brain and spread even more 4 days post-injection, while at 5 days we see a reduction of the expression of the antigen in different areas of the brain. And so to address this reduction of expression of the antigen 5 days post-injection, what this study did was trying to quantify the density of the neurons, hypothesizing that actually the virus could induce neuronal death. So here we have in white the control mice which were not treated with SARS, and in black those mice that were treated with SARS. And what we see is that 4 days post-intranasal infection, areas like the anterior olfactory nuclei, infralimbic cortex, and cingulate cortex, they all show in SARS-treated mice a reduction of the neurons, so of the density of the neurons, so increased cell death. Other areas like hippocampus and the cerebellar nuclei were not affected by it. But the reason could be quite easily that those areas are infected by the virus later in the timeline, and so might be affected, and we will see neuronal death later in time there. So this experiment shows quite nicely how the virus can actually, from the nose, reach the brain and diffuse from the olfactory bulb to different areas of the brain, which are not necessarily processing the olfactory information. This is, of course, applies to SARS, but we should not forget that AC2 is also a factor for COVID-19, and also there are many similarities between SARS and COVID-19. We can also not completely exclude that COVID-19 will not follow this pathway, of course. So, but what we can do right now is to keep this in mind and try to keep an eye on all the patients which have been affected by COVID-19 in case we will have some symptoms of neurological disorders. So in summary, we can say that approximately 23% of all olfactory loss cases are caused by upper respiratory infection. And patients which have olfactory dysfunction due to an upper respiratory infection are more often hyposmic, so have a reduced sense of smell, than anosmic, so having no sense of smell at all. Qualitative olfactory dysfunction are also pretty common in those patients with olfactory loss due to post-upper respiratory infection. Last but not least, we have to keep in mind there's no effective therapy for a post-viral olfactory loss, but we know the time is helping a lot. So what we know from the current COVID-19 outbreak is that patients which have been infected by the virus also present olfactory and taste disorders, and that by the analysis of the RNA sequences, we can have a certain idea of how the olfactory epithelium could be affected by the virus. And surprisingly, the virus doesn't seem to be able to attack directly the olfactory sensory neurons, but will attack the supporting cells. Damaging basically those cells, it will damage the overall healthiness of the olfactory epithelium. Last but not least, we know that for SARS, viral infection can spread from the peripheral nervous system to the central nervous system using the olfactory pathway. Now, we don't know if COVID-19 can do the same, but we want to keep it in mind that this is possible. In conclusion, the current COVID-19 outbreak might cause a significant increase of individuals with a permanent olfactory loss or impairment. And what we want to do is act very promptly and take this opportunity to understand post-viral infections too, and under different point of view. On the pathophysiological point of view, trying to figure out why this is happening. On the recovery, we can keep track of all those patients that lost their sense of smell and how this dysfunction will develop in time after the infection. And last, but most importantly, we can collect more information to be able to design a therapy in order to improve possibly the sense of smell of all of those that are affected by the virus. I hope this was clear, and now you could have a better understanding of what does it mean, upper respiratory infection, and the loss of sense of smell due to it. If you want to learn more about anosmia, olfactory dysfunction, and in general know more about the Monell Center, I invite you to look at our homepage. Check out the part on anosmia, but also just what kind of research we are doing here in Philadelphia. Also, if you are experiencing smell and taste disorders due to COVID-19, there's another big resource and also another big help you can give us participating to a survey by the Global Consortium for Chemosensory Research. We are part of this consortium, and we are trying to figure out how smell and taste are affected by COVID-19, but also other upper respiratory infections.